There is naltrexone, which is long-acting naloxone. So it's the blocker. It's the antagonist. It's high affinity for the opioid receptor, and it's indicated for both opioid use disorder and alcohol use disorder. Well, wait a minute. It's an opioid blocker. How is it indicated for alcohol use disorder? Well, maybe something to do with that final common pathway. Maybe something to do with dopamine release in the nucleus accumbens, whether it comes through the GABA-A receptor, as in alcohol or benzos, or whether it comes through the mu receptor. It's approved for use in 97. It's available in an oral form, which is the 50 milligram tablets, and the depot injection form, which is extended release naltrexone or Vivitrol. And it's every 4 week, injection. If you're going to use the tablet, sometimes there's a little bit of a GI tolerability thing, and you have to start with 25, half a tablet. Naltrexone blocks the effects of opioids and the euphoria from alcohol. So that's another thing. They think that maybe it's, some of the dopamine release in the nucleus accumbens, but they can't pin it down, because it's not easily explained why naltrexone works so well. And when I say it works so well, it beats Antabuse and it beats Campral, which is acamprosate. So there's only 3 actually approved medications for alcoholism. The advantage of naltrexone is it's inexpensive, no abuse potential. It's useful if you need to function in safety-sensitive work where access to narcotics continues to be present. There's no neurocognitive impairment issues. Legal court system supports its use. Disadvantages, it's a monthly injection. It can be costly. But I tell you, people who are using the oral naltrexone and they still have breakthrough cravings for alcohol, the injection is sort of much stronger, much better. It's probably the smooth, the serum level that stays level and they get coverage 24/7. The spike on the oral medication is sort of on and off, and but it seems to work much better on the injection for cravings of alcohol. You need a coordinated need for with other providers if you're going to go under surgery and stuff like that, because it is full, it's an antagonist at the mu receptor, so you might have some problems. You will have some problems with analgesia, perioperatively. Now, think about that with opioid. It's indicated for both opioid use disorder and alcohol use disorder. But think about it, right? You're coming in, your dopamine levels tanked, and you're really looking for a little more dopamine initially. And that's what buprenorphine is kind of going to give you. If you go onto a blockade, you're blockaded. I mean, you're not supplementing the dopamine per se. You're basically, I wouldn't say forced abstinence, but you're basically not going to use that substance because it's not going to get you anywhere. But I might start, drinking, or I might start trying cocaine or something else. So it's a tool. It's helpful, but you also have to be aware if you're using it for the indication of opioid use disorder. If you miss an injection, their receptors, everything kind of resets to a degree. And if they went back to using the opioid at the same dose they were using before the shot, the risk of overdose is high. One of the caveats to resetting the neurotransmitters. More about naltrexone. Does the patient's diagnosis and risk level fit my practice capabilities? If yes, move forward in instituting medication and monitor closely. So let's assume in this case you're using naltrexone. The question still remains, I'm checking them for withdrawal. Do they need detox or do they need naltrexone? So I don't want to confuse, naltrexone is not detox. If somebody's shaking and they haven't, they're in the middle, they drank like last night and they're shaking in front of you, naltrexone is not the answer in the moment. Detox is, right? So conduct your CEWA score and a thorough history, including quantity and frequency of drinking, previous withdrawal experiences, other substances currently using, urine drug screen to confirm, opioids. And if you have an ETG, you can see when they last drank. If it's, I haven't drank in a week, but their ETG is positive, then they did drink. unless they took a bath in hand sanitizer. So you're going to look at that dimension 1. What is their risk rating? And do I start with naltrexone, or do I do a slow, maybe they need a little bit of a monitored outpatient kind of equilibrium, or kind of a short detox. But again, because the stakes are high, this is a case where you might not do an outpatient detox in somebody suffering from alcoholism unless you have that support person. Because what happens if they drink on your Librium at home alone? You may have just, sort of been party to a big, big problem. So in the case of you figure the person's in front of you, you want to use naltrexone, but you need a bridge. I first got to get this person a week or two off of alcohol so that I can institute my naltrexone. So how do I do that? Well, I bring in the support person. We do a short course of Librium with the support person, and they can't drink on it, or it could kill them. So you get over that hump, and after that 1 to 2 weeks, you put the naltrexone on. That would be the ideal way to kind of use that. So if the patient's diagnosis and risk level fits your practice capabilities and they're determined to be low risk, or they just completed detox and they're coming back to you because they went to the unit and they're sort of, a week or 2 weeks off drinking, and they had their detox in the hospital or with someone like me, or, then you can go ahead and do the naltrexone tablets. I wouldn't be afraid of them. I had a primary care doc who was writing for all kind of psychotropics, but they were like, oh no, I won't touch that naltrexone. That's a specialty medicine. That carries heavy risks. And the truth is it's very well tolerated, very safe, and there's a dozen other medicines we use which are much more scary than naltrexone that we use routinely in primary care that are not, risky, or that are risky, and this one is not risky, is what I'm trying to say. So go ahead and put it on there if they have, they're finished their detox or they're not detoxing, and you've determined that their ASAM risk level is lower. This is a great intervention with well tolerated. I mean, if you wanted to be extra careful, they only come in 50 milligram tablets, so just split the tablet in half. Do half tablet dosing and do it with food. Some people get a little bit tired with it, so if you want to be extra cautious, you can do it at night with food, half a tablet. But otherwise, most people, I just often go right for the 50 square away right in the morning, because the way the serum levels look, it's good to just get it going at a therapeutic dose. So you could also go for the 50 right in the morning. It's been shown to reduce the rate of return to heavy drinking in the short term. Reduce the rate of return to heavy drinking. Funny, I don't see the term abstinence on there. Does anybody see that term abstinence, that it makes them abstinent? So instead of having 12 drinks, they might have 6. Instead of having 6, they might have 3. I think it's a movement in the right direction. Is it fixed? If they had pancreatitis and they were recently in the hospital and they're having 3 drinks instead of 6, are you guys happy? So it's, again, not one size fits all. It's just knowing what is the tool I have in my hand, what is its capabilities, what do I really expect from this medicine? And what you really can expect is that it might shave some off. It might shave some intensity off. So that's helpful. Reduce the rate of return to heavy drinking. Avoid now, if you check the LFTs, you'll have to see how much above the upper limit of normal. In severe liver damage, you wouldn't use it. You can't give it with recent opioid use for obvious reasons, because it's a antagonist, and it'll put people into withdrawal if they have any opioid, including buprenorphine, in their system. This will precipitate their withdrawal. So you got to make sure there's no opioid or opioid-like substance. You can try something called a naltrexone challenge test, where you do a quarter of a pill or, some very small amount, and and see that they're not in withdrawal. If you're concerned, you're not sure if they're on opioids or something, you can give them a brief challenge either in the office at home to see. The side effects it's well tolerated, but I have to mention the most frequent, 2 or 3 that I see is like nausea, headache, or somnolence. I put decreased appetite on there because that's, as you know, they've combined that with Wellbutrin, and they put, bupropion and naltrexone together with Contract to make it appetite suppressant. So it's, some idea about what does it do to appetite. And now we're back to that survival center. Food and water goes through there. So how could naltrexone decrease appetite? Well, there's a lot more to be discovered. So the second FDA-approved medication is Camprol. Acamprosate is the generic. Camprol is the trade name. Structurally, it's similar to the amino acid neurotransmitter GABA. So it's a GABA analog. Now think of like GABA and glutamate. GABA is the brake, glutamate is the gas. In the central nervous system, GABA modulates to calm things down. And glutamate is the excitatory neurotransmitter. For lack of a better analogy, I talk about MSG, monosodium glutamate. It was in my food and my heart is racing. Just something so you remember it. Glutamate is the gasoline that causes anxiety. This is a modulator of the GABA glutamate system. It works on the NMDA receptor as an antagonist. So it's thought to balance the dysfunction in glutamate and GABA seen in chronic alcoholism. Oral medication taken 3 times a day. Side effects, sometimes GI, but very well tolerated. Compliance can be a challenge because it's TID dosing, and the naltrexone we briefly talked about is once a day dosing, and this is 3 times a day dosing. So that TID can be an issue. Now, this is okay in renal dysfunction. In liver dysfunction. You got a liver problem, you can take Acamprosate. But if you got renal dysfunction, you have to be careful right at that 30 cutoff. Creatinine clearance less than 30. And then less than 50, you might want to change the dose. But, it's not metabolized by the liver, so it has that safety going for it. Significantly reduces the risk of return to drinking and increasing the cumulative duration of abstinence. However, Acamprosate appears to be no more efficacious than placebo in reducing heavy drinking days. So what are we saying here? Some practitioners, this is the one, maybe you institute it while somebody is drinking because it doesn't have that liver issue. And, but it doesn't kind of decrease the amount of heavy drinking days. It just sort of has a chance to extend abstinence if they get into abstinence. Another tool in the toolbox. Here's what Camprol does. It increases the GABA and basically decreases the glutamate. And so, when you're looking at what alcohol does, it sort of does the same thing. It increases GABA. So while I'm taking alcohol in, so this is alcohol's direct effect on my central nervous system, neurotransmitter. So GABA's up, so I'm relaxed, right? That's the break. But when I'm coming off of alcohol, GABA's down. And guess what's up? Glutamate's up. So the bottom, the N-methyl D-aspartate, NMDA, glutamate receptors, glutamate activity is high in withdrawal and low in intoxication. So this is the illustration of the brake and the gas. GABA being the brake, glutamate being the gas. And so I'm always in a state, if alcohol is the substance in question, when I'm taking the alcohol in, I'm in an intoxication state to some degree. When I'm not drinking, whether it's while I'm sleeping or any other part of the day, I'm in a low level of withdrawal. And there's no escaping that cycle. So I'm either in a low level of intoxication or a low level of in withdrawal perpetually if I'm in the cycle of alcohol use disorder. And so what this does is tries to offset. But we have to be careful. It's like we want to know how to use them, but keep your expectations modest. What we have is a wave that's about 6 feet tall in the ocean, and we built a 2-foot berm. And we're expecting that 1 to 2 foot berm to hold back that 6-foot wave. You know, the amount of excitatory and inhibitory neurotransmitters from a fifth of vodka, it's hard to compare with a dose of Campbell or acamprosate. You get what I'm saying? So you need to be able to have the person at the right level of care. Disulfiram's been out forever. That's Antabuse. It inhibits aldehyde dehydrogenase. It was approved originally in 1957. How well does this one work? In the right setting, produces severe nausea and vomiting. But boy, that next one's a doozy. Cardiovascular complications and or collapse. So there is a problem. You know, if I drink on this thing, I mean, I might just get nausea and vomiting, or I might get something else. So there's a little bit of a risk there. It's an aversive therapy. It's not widely used. Compliance issues affect the efficacy because folks choose not to take it. Just, I'm not taking it today. And the half-life is basically out of the system the next day. Then there's some mental health stuff. It can potentiate psychosis in susceptible individuals, may have some utility in cocaine use disorder. What I want to say about it is it's very useful in the case where I am trying to earn trust back. I want my family to know I'm serious about recovery. So I will take this in front of them every morning at breakfast. It's not for me. It is for me, but it's not for me. I take it to give a little bit of reassurance and build trust back to the people that are close to me. It's a valuable tool in the right hands and used the right way. It's not for everybody, but in the right setting where I'm trying to make a point, you can use it. And it can be combined with other medications, whether it's naltrexone, Campbell, or Antabuse. To some degree, all three of them can be used. This is the pathway. If I'm a fast metabolizer of the enzymes that metabolize alcohol, these convey a higher risk of alcohol being picked as my substance of choice. Again, I can independently have addictive disease as defined by what? Low dopamine in the nucleus accumbens. If you learn nothing else today, that's the disease we're fighting. It's not alcohol. It's not opioids. It's the main disease. So, if my chemistry, because of heredity, I have fast metabolism of alcohol dehydrogenase, and I have fast metabolism of aldehyde dehydrogenase, and I skate right over to acetate. Acetate has no adverse effects like nausea, vomiting, headache, flushing, and hangover. I get no hangover. And it goes good with me. Alcohol's it. I found it. It's everywhere. And it goes good with me. I rapidly produce it, and all these people talk about all these adverse effects. Well, it ain't me because I metabolize it well. There's some folks that I have the disease of addiction, but darn it, I can't choose this as my Band-Aid or my substance of choice because aldehyde dehydrogenase is slow. I may fast metabolize alcohol dehydrogenase, but I get stuck here at acetaldehyde. And what does that give us? Flushing, nausea, side effects, miserable feeling, hangover. It ain't for me. So that's just one way that metabolic pathways, genetic predisposition, the way my body is wired, in a way, I choose the substance or the substance chooses me. Nicotine, the new gateway, vaping. Darn it. Nicotine is the primary agent in regular cigarettes and e-cigarettes. It's highly addictive. Is it that nicotine is the highest addictive substance, or is it the route of administration? Remember I said earlier, the fastest way to get a substance to the brain in the nucleus accumbens is what? Inhaled. So that plays a lot into it. The fact that this starts with inhalation. There's, that's a part of it. Among youth, e-cigarettes are more popular than any tobacco product. 2021, National Youth Tobacco Survey, more than 2 million U.S. middle and high school students reported using e-cigarettes. And at face value, it has negative cardiovascular and lung effects and unknown chemicals, but I'm scared to death of it because of the addictive liability and the fact that these folks who may have a genetic predisposition for the disease of addiction are going to get introduced to a fast-on, fast-off modality that will mess with their neurotransmitters, will mess with the dopamine, spike and drop it, and it'll just play into the cycle. So it's quite unfortunate, but I'm not sure. Other than education and treatment, what we can do. So tobacco and nicotine still, 480,000 people die in the U.S. from smoking-related disease, according to the CDC. Medication at least doubles the quit rate from nicotine-containing products. A lot of stuff with Chantix, but what I want to bring out is varenicline. Varenicline is a partial agonist at the nicotine receptor. I want the theme to come across that partial agonists may be helpful in treating addiction because we're looking for an effect but not a big effect. Any full agonist might give a spike, but a partial agonist might give me just some stimulation at the receptor where nicotine hits to produce the dopamine. Because smoking cigarettes or vaping, again, final common pathway, dopamine release in the nucleus accumbens, right? So if we can get a partial agonist it doesn't release 200 to 300% supra-physiologic amounts of dopamine on ingestion, but more moderate amounts. They don't deplete my neurotransmitter stores. Maybe I get enough time and a fair fight that I can learn other coping skills to deal with stress or address the low dopamine problem. But, there were some things out there, as you all probably know, with regard to contaminants inside of the manufacturing product, and then cardiovascular problems. Well, one thing is it appears as more people are dying, from the nicotine and cigarette smoking than have died from varenicline. So I think it's still possibly a very good option in some cases. Bupropion and nicotine replacement therapy over-the-counter also effective. More on bupropion, that's generic for another trade name is Wellbutrin. Stimulants and cocaine. No FDA-approved medication-assisted treatment for stimulants or amphetamines for cocaine yet, but if you haven't seen some data, NAC, mucomist, going down for a CAT scan. I need renal protection. What are we going to do? Well, in the case of cravings for stimulants and cocaine, it seems like, we don't exactly know how, maybe the glutamate modulation helps reduce cocaine craving for methamphetamine and cocaine. Again, not a miracle, but you know what? We'll take anything that can help. And it seems this is now, still primarily the way I'm, when I use it, it's over the counter. It's 600 milligrams, two tablets twice a day, total of 1,200 milligrams, or at least 600 milligrams twice a day. But it seems to help. We don't have a lot in the toolbox. There's some studies out there. I didn't cite any particular ones here, but you'll be able to find it. Where you'll see, some data on the efficacy of NAC or N-acetylcysteine for stimulant. Bupropion, a long-acting norepi, and lo and behold, there it is, dopamine reuptake inhibitor. Anything that's a dopamine reuptake inhibitor, we might have use for that in this disease. Low dopamine is the core problem, so you're telling me I can get maybe more dopamine in the central nervous system without a spike and a drop? Maybe. But we like the extended release. There's an immediate release, a sustained release, and an XL. You gotta go with the XL. Like almost everything in addiction medicine, anything that's IR is going to be cautioned for spikes of dopamine. So the super extended 24-hour half-life long version of a norepinephrine dopamine reuptake inhibitor may be very helpful because those are some of the neurotransmitters really out of whack with stimulants. Stimulants work by a different mechanism. They inhibit the reuptake of dopamine. So the transporter, the dopamine transporter is inhibited. So you got a lot of dopamine left in the synapse that degrades, and they have a real tough time with adequate levels of dopamine. So it seems to work. Long-acting sustained-release stimulant medications, oh, there it is, may have a place in stimulant use disorder or cocaine use disorder treatment. Research is ongoing, so that's, never thought I would say the words. Never thought I would. Extended release, Schedule 2. Extended release may have a place in treatment of this illness, particularly with cocaine and methamphetamine. They're looking at that. But one thing I feel really strong about is not the immediate release preparations. That immediate, quick release amphetamine that's fast on, fast off, no good. Because it approximates cocaine. It approximates methamphetamine. It's fast on, fast off. If there's going to be a help, it's going to be slow on, slow off. Slow on, slow off. Without the spikes. So research is ongoing where they're looking at stimulant medications to treat stimulant disorder. But, hey, stranger thing, buprenorphine, an opioid to treat opioid use disorder. In refractory insomnia issues, is sort of aside, but important. Folks that have, I can't sleep. There's nothing that works, nothing that works. But by now, you guys probably all know the quetiapine secret. That works. That works when trazodone doesn't work. That works when Remeron doesn't work. That works when hydroxyzine doesn't work. That works when your Ambien doesn't work. That works when low-dose quetiapine, not at the doses for bipolar or schizophrenia, but low-dose quetiapine works for sleep. And it even works in people coming off stimulants or cocaine, so that's a pretty helpful tool when you have somebody really jazzed up and can't rest. Of course, you're going to have to sort of take a look to make sure they don't have obstructive sleep apnea or central sleep apnea or another problem with their sleep. But as a tool in the toolbox, you can get people sleeping reliably. Night terrors, that's another thing that you see in trying to treat this illness. We're looking at maybe the alpha-1 blocker, the blood pressure medication, prazosin, start at 1 milligram at night, decent for night terrors or nightmares. Cannabis use disorder, sedative hypnotic use disorder. There's not FDA-approved MAT for these yet, but meds provided to address specific symptoms associated with withdrawal, like anxiety, insomnia, are helpful. You might even classify them as like medically assisted withdrawal management, or a new term, you might put that in the library, post-acute withdrawal symptoms. That's stuff that carries on long after I'm done with the substance. I mean, that can go months. If I'm on benzos for 10 years, guess what I'm going to have 3 months into it? I'm still going to have low-level withdrawal stuff, opioids. So you can use a long-acting, for a short time, you can use chlordiazepoxide for kind of just bringing them down, but not beyond a few weeks, 2 or 3 weeks. Of course, if somebody has questionable liver function or they're older, then you might use lorazepam because the metabolites of the Librium are horrible in some folks or older. Worth mentioning the Ashton Manual. That's a good read if you have information. Evidence on management of long-term benzodiazepine use and tapering medication. There's, even suggested schedules in there for benzo tapering. When you're looking at taking somebody off, you might take 6 months to a year to take them off their benzo. And they have some recommendations in the manual how to do it. Gabapentin might be a decent tool to use for longer-term symptoms when you're getting somebody who's coming off of years and years of benzodiazepines. Hydroxyzine, clonidine, ondansetron, trazodone, propranolol, and quetiapine are all commonly used in treating people with cannabis use disorder and sedative hypnotic use disorder. So we, almost like a blanket, we call like recovery-safe medications. There are some medications that we feel good that they don't spike dopamine. And so, these are kind of trusted tools in the toolbox for us in addiction medicine to say, look, they're not going to really cause the disease to go backwards. And just a reminder before beginning these things, just make sure they don't need, that ASAM level 1, that dimension 1 detox. So here's the sort of summary sides. Medication-assisted treatment effectiveness in treating substance use disorders, improves survival, increases retention in treatment, it decreases illicit opioid use and other criminal activity, increases patients' ability to gain and maintain employment, improves birth outcomes among pregnant women who have substance use disorders, decreases risk of contracting HIV or hepatitis by reducing relapse rates. A lot of good things that medication-assisted treatment does for the patients, for society, and reasons to do it. It appears to be the most effective when combined with multiple modalities like psychosocial treatments like therapy, counseling, and at the level of care as indicated by your assessment. So when you rate them in those 6 dimensions, in their high risk or low risk, that will dictate, does it happen in my office? Does it happen in someone else's office? Or do they need to check in somewhere or to a program that's a specialty? The other things, mutual support groups, 12-step facilitation, group therapy, individual therapy, counseling, and other non-pharmacologic approaches, as well as treatment of comorbid psychiatric conditions are important in the comprehensive treatment of the disease. Buprenorphine is an important option for patients with co-occurring chronic pain and substance use together, particularly if they have opioid use disorder. Addiction is a chronic disease, and as with every disease, the severity of the condition must be assessed, appropriate treatment recommended, and follow-up established. Without the follow-up, relapse is likely, and the ASAM criteria and the dimensional assessment provide the framework and the picture and the data to recommend what level of care is needed for the patient with or without the medication component that correlates with the highest likelihood of treatment success or full remission status. A multidisciplinary team with multiple modalities, including MAT, individual therapy, group therapy, family therapy, as well as outside sober support is often the key for successful treatment for moderate to severe addictive disease. And mild disease, as we were talking about, you might be able to address that on an outpatient basis.